Happy Friday, everybody. Welcome to Keymont Grand Rounds for today's the 12th, right?
Yes, you're correct.
Yes, sir. December 12th. December 12th. All right. Today we have the pleasure of hosting Dr. Cheedy Jaja, who's visiting us from the University of South Florida. And so he's going to be talking to us about advancing care for sickle cell disease. Again, using the Sierra Leone nursing champion model. But some brief background here. Here we start. So, Dr. Cheedy is an associate professor in the College of Nursing at the University of South Florida in Tampa. He also has an adjunct research appointment in the Department of Emergency Medicine at Augusta University in Augusta, Georgia. So we are familiar with them. And at the College of Medicine and Allied Health Sciences at University of Sierra Leone. He just came back from Sierra Leone. Okay. He's a board certified psychiatric and mental health nurse practitioner, so something we could definitely meet around here. And his research focuses on sickle cell disease, pain, pharmacogenomics, and genetics, and health justice and health policy. Some of the formal education background, got his Bachelor of Arts at University of Sierra Leone some years ago. And then, seriously, I'm not joking, he has 6 master's degrees, 6. Not that it's not, but they're not. You didn't repeat anything. It was a sort of like just masters in different things. Some of them are masters of arts. So he has a master of arts from Bowling Green, a couple of masters of arts from Bowling Green, and also from Ohio University, Florida Atlantic. That's where he got his doctorate, his PhD at Florida Atlantic. Indiana University, did a postdoctoral fellowship, University of Washington in Seattle, master of public health, so MPH there. And so not all just math, not just masters of arts. University of Washington, masters of nursing, and then Indiana masters of science in nursing. So a lot of master's degrees. Because, we have to get out of school at some point.
I'm the poster child for career decision.
For career decision making. All right. Some other interesting career highlights. He was a hemoglobinopathy counselor at one time. He completed the Ebola clinician training. He has an Ebola, taking care of patients with Ebola virus. So, an Ebola clinician training certificate. He was an air traffic controller. I don't even, I'm going to stop on that one. There's so much to say there, but that I don't need to. Currently, as I said, he's associate professor. He's been a Fulbright scholar. Anyway, somebody who's been very dedicated to the care and democratizing care for patients with sickle cell anemia. And I'm looking forward to hearing about the nursing model again. Welcome, Dr. Cheedy.
Thank you. Can everybody hear me clearly? I speak with an accent, or you could say I speak funny, so just try to listen funny, okay? All right. Thank you, Dr. Lockhart, for inviting me to spend time with you and colleagues online. Everything that Dr. Lockhart said, I think the most important thing that I want you to take away from this talk is my passion for sickle cell disease and my dedication to the patient population. I'm happy I had the opportunity to share with you some of the interesting work that I've been doing in Sierra Leone. But I like to put things in context. Move. It's not moving. Okay.
Sorry, we can't hear anything here online.
Can you hear us now? Yes, you can.
Yep.
Very good. Back and forth. Yeah, it's just like a 3 to 5 second delay. Okay, does that work?
So I want to put my talk in the context, of the interesting work that's been done here at MUSC around the Werner N. Grant Sickle Cell Center. Okay. And my understanding is that this is gearing up to become the central hub where patients with sickle cell disease can have access, to the innovating disease-modifying therapies that are now coming online for sickle cell disease. And across the state, there will be dedicated facilities that are going to serve as the spokes, where patients, in addition to having access, to these disease-modifying therapies, can now be offered longitudinal care, these sites for monitoring, as well as supportive management. I think for such a vision to succeed, there are 3 essential elements. For this vision to succeed, there are 3 essential elements. One is that you have to use alternative workforce models, to increase your healthcare providers. Okay, you also need to be very innovative in terms of how you use telehealth to integrate clinical care. And thirdly, you also need to have models and strategies in place whereby, equity will be the focus of how care is being managed or implemented. And so for my talk today, I'm just going to focus on the first item, which is capacity building through task sharing. So basically what I'm trying to say here is that you need to think of innovative ways whereby you could use your existing workforce to ensure that everybody who is part of your cohort or part of your service population can benefit from the care that you propose to offer. Okay. I'm going to demonstrate that by showing how I use a strategy in an environment outside the United States. All right. So in terms of my agenda, since I'm trained as a nurse, I want to show how nurses, or I will use nursing to promote good science and clinical care. I also want to use sickle cell disease, as my exemplar, but I'm going to focus on a model called the Nurse Champion model. It could also be called the PA model. It could also call the physician model. It just depends on which clinician is the focus of your intervention. And I'm going to use Sierra Leone as my template where such a model can be implemented. I don't know how many folks are familiar with this graphic, but it actually gives you the disease burden of sickle cell disease in terms of the part of the world, or the region of the world where this burden is highest. And as you can see here, Africa is where you have the greatest, in terms of the incidence rate, the largest incidence rate, as well as the prevalence rate. Okay. But I think my next slide kind of like put things in perspective in terms of the burden of the disease. Okay. And clearly you could see that Africa is the part of the world, with the highest burden, which for me means that for us to succeed with sickle cell disease globally, we have to get it right in Africa. And so that's the impetus for why I do the work that I'm currently involved in Africa. But there's also another reason why we also need to focus our work in areas where the disease burden is greatest. Okay? Here in the United States, each year, I think I might be wrong, but well, not to all. I think about 2,000 babies are born with sickle cell disease in the United States. I mean, do you have a different figures? But I'm sure it's not more than 2,000. Okay. But in Africa, on a daily basis, about 1,000 babies born with sickle cell disease. Every day, 1,000 babies are born with sickle cell disease. But geography determines not only your life chances with sickle cell disease, but your life expectation. Here in the United States, kids born with sickle cell disease have a 95% chance of surviving way into adulthood. In much of Africa, in sub-Saharan Africa, kids born with sickle cell disease have a 10% chance to survive beyond their 5th birthday. Okay, so because of that, sickle cell disease is recognized as a silent killer in Africa. And so several world organizations, the WHO, UNESCO, UN, recognize that actions are needed by nation state, African countries, to begin to implement programs for early diagnosis and clinical management of sickle cell disease across the lifespan. Recently, the Lancet Hematology Commission published a white paper on sickle cell disease with particular focus on what is needed to improve the workforce that is globally available for sickle cell disease. And with a focus on how can we increase that pool of healthcare providers rapidly to ensure that patients with the disease benefit from existing intervention, standard of care, but also the emerging therapies that are currently on the landscape. Okay. And so for me, again, as a nurse, as a trained nurse, I started thinking about, well, how can we get nurses involved, in this, creation of an alternative workforce to serve sickle cell patients. And I have a lot of good partners, who have, in a way, made the case or tried to make the case of why nurses should be involved, not only in clinical care, in research, but also in administration and development of policies for sickle cell disease. Okay. And of course, the year 2020, was when we were supposed at the global level to see how nurses, could do all of the 4 things that I've outlined. And 2020 could not have been a better year because nurses rose, to the occasion. Okay. So what I've been doing is thinking about strategies where how we could use nurses to help strengthen existing healthcare system, but at the same time, build nurse clinical capacity. And I've been doing this work in a country in West Africa called Sierra Leone. Slide is delayed. Come on. And Sierra Leone is a tiny country in West Africa, and I want to urge you before you die, it's a place to visit, right? You will not regret it. Perspective. So, in case you don't know where Sierra Leone is, it's a very tiny country in West Africa, population of about 8 million people. And I got involved in Sierra Leone in 2014 if you guys recall what happened in 2014 in that part of the world, West Africa, was the largest Ebola outbreak in the world. Okay, so 3 countries were simultaneously impacted by Ebola. And for better or worse, I decided I got to be, in Sierra Leone and to help, with that effort. So I spent about 6 months. I did 3 tours of duty, actually working in multiple Ebola hospitals, caring for Ebola patients. And in fact, that's how I got familiar with the hub and spoke model. But at some point in time, I actually end up managing several Ebola clinics, across the country. But it was a life-changing experience, to say the least. But it is what really convinced me that if I were to make, a contribution caring for sickle cell patients, that's where I need to get started. So what I've been doing then in Sierra Leone is beginning to develop, an infrastructure for management and care for individuals with sickle cell disease. Well, why is Sierra Leone important? Okay. Sierra is important in the sense that despite its small size, and small population, about 8 million people, when you look at the global burden of sickle cell disease, Sierra Leone ranks between 7th and 9th based on the statistic that you chose to use. But more importantly, about 5,000 kids, we were between 4,000 to 5,000 kids are born with sickle cell disease annually. And here we're only talking about the SS and the SC variant. We don't have any statistics for the beta thalassemias. Okay. But again, because there are very few infrastructure to manage these kids, between 60 to 90% of the kids would die before age 5. Yeah. Limited infrastructure for their care. Yeah. The government of Sierra Leone is aware that sickle cell disease is a major healthcare problem. In fact, this is a white paper that was published in 2018. And I was part of a technical working group that prepared this document. And here we have a very clear outline of what is it that is needed to begin to tackle or address the burden of sickle cell disease in this country. So train healthcare providers, establish centers of care, introduce wellness care, improve supply chain. So the whole gamut, so a very comprehensive plan, that would, if implemented, would begin to provide patients with sickle cell disease the care that they deserve. Okay. But because of lack of resources, nothing was done with regards to implementing the white paper. So I decided, well, something needs to be done. And I was able to put together a group that comprises of some of my colleagues at institutions here in the United States, but also work with local partners in Sierra Leone, the university's medical university in Sierra Leone, patient advocacy groups, and interestingly, with a federally qualified healthcare center that was based in Buffalo, New York, that had a global mission in Sierra Leone. Essentially, they had a huge community health clinic, and that community health clinic became our medical home for our project. Okay. And we had 3 specific objectives for this group. Okay. One is that we're going to establish a model wellness program that we implemented in clinics across the country. Okay. Secondly, we're going to develop curriculum that we could use to train healthcare providers how to manage kids with sickle cell disease. And thirdly, because I'm also a research scientist, I want to study how the natural history of sickle cell disease manifests in an environment where there are limited resources and compare it to how the disease manifests itself here in the United States, where we have, better, resources. And again, as research scientists, I needed to have a model. And the model that I chose, or the North Champion model, has two essential ingredients. One is that you determine the particular task that you want to train the individual or the nurse to do. Okay. And then you provide all the resources, the training that are relevant or required for that individual to be able to complete that task. The concept that we use is called upskilling. Basically, you just train somebody to do a specific task. And once they're trained, then you can now task shift. That task becomes the priority of that individual. And so that is the model that we decided to use in Sierra Leone to enable nurses to do a variety of tasks that would be beneficial to patients with sickle cell disease. Okay. Now, our scientific platform, we use implementation science. And what I really like about implementation science is that it allows you to do research that would otherwise be considered messy, in the sense that you don't try to control your environment, you work with the environment. And you make adjustments and corrections, as they manifest itself. So you're doing your work in real time. Okay. So the North Champion model and implementation science underpins the work that we do in Sierra Leone in terms of introducing new service and new models. And we follow a basic strategy. Three steps or three phases. The first phase we refer to as formative evaluation. So say I want to introduce newborn screening, in an environment where newborn screening is absent or have not been implemented. Okay. I don't assume that I have all the answers in terms of how I could implement the program. So the first thing that I need to do is I need to put together all the key stakeholders and have a dialogue, with these individuals so that I could learn in that particular environment, what are the enablers? What are the things that will allow such a program to succeed? I also want to understand, what are the obstacles that would result in the failure of of that intervention or that implementation strategy. Okay. So with that dialogue, and I'll get a sense of how I could implement or how I could begin to design my intervention. But it also gives me an idea of what I need to be cognizant of when I train the individuals who are going to be implementing that intervention or that model. And that takes us to phase 2. Okay. And then phase 3 is I've now designed my intervention. Okay. I'm going to implement it, but I'm also going to be evaluating it in real time to see how I could overcome the obstacles that emerge roundabout during the implementation. Okay. And we call that process evaluation. And at the end of the intervention or the implementation, I also want to do a summative evaluation to understand how the project is unfold, okay, what needs to be tweaked, and what do we need to do in terms of sustainability, in terms of upscaling and so forth. Okay. So all the interventions, so I'm involved in several different types of intervention in Sierra Leone, all around sickle cell disease. But this is the backbone of how those interventions are implemented. Okay. Start with talking to key stakeholders, learning from them, use that information to design the intervention, implement the intervention, and the required training, design the implementation, and then the training curriculum, train your workers, and then you implement it, evaluate, observe, and make changes during the implementation phase. Okay. So now, what have we been doing in Sierra Leone? Well, before we talk about that, the reason why the infant mortality in Sierra Leone is high is because, like many sub-Saharan African countries, there are no established newborn screening program. And this is because those programs, if you use a conventional model, tend to be very expensive. And most countries cannot afford to use that model. But things have changed. We now have in the market a number of commercially available point-of-care tests that are low cost and don't need reagents, constant electricity supply. And they have the same or sometimes even better technical capabilities as the conventional lab models. And we've been able to use some of these point-of-care tests in Sierra Leone. And often what you need is just a tiny drop of blood. Okay? And I don't know if any of you guys have worked with a rapid malaria test, but they operate on the same principle. Tiny drop of blood, and within 5 minutes, you'll get a result. And based on the test that you use, you could get a variety. Your options could range from 2, 3 phenotype to as much as 7 phenotype, okay, based on the test that you use. Okay. But again, the result is rapid, and you receive the result at the point of care. So these tests, or availability of this test for us was a game changer in a country like Sierra Leone. Now we could go out in the community and do point-of-care testing and determine the status of individuals in real time. And so here, this is, well, she's not my colleague, but she was my PhD student, and then she's now faculty at Duke. We're out here in the community screening all the kids to determine who has sickle cell disease or who has sickle cell trait. Okay. Following that, our next program was, would this point-of-care test work in newborns? Okay? And so in the history of Sierra Leone, these kids are the first cohort to be screened for sickle cell disease in the history of the country with point-of-care testing. And we did this test January 1st, 2018. So these kids are my hero. I always show the slide wherever I go. So being able to identify kids with sickle cell disease now position us to begin to develop a sickle cell clinic. So we developed the very first pediatric sickle cell clinic in the country, using the facility that was owned by the Federal Qualified Healthcare Center that I mentioned. Okay? And this is what it looks like. And when we started providing care, for our patients, we used the NIH sickle cell guidelines that was published, I think, in 2014. And these are the presentation we saw, in our patients. And these are presentations you will never see here in the United States. Okay? This is a result of lack of limited care or lack of access to care. But I like this other slide because what you see here are what our kids look like after we start providing care for them. Okay? And they have my stethoscope because I am certain that they're all going to be doctors and nurses when they grow up. Okay? All right. So now let's talk about the work that the program that we've implemented in Sierra Leone. Okay. So one of the programs is using point of care tests at the bedside by nurses to identify children with sickle cell disease, and then coordinate follow-up care for those newborns, who would deemed to have sickle cell disease. And this program was supported by NIH. It was a out-21 mechanism, but what's really different about this out-21 is that it was for 3 years as opposed to just 2 years. So we trained nurses, how to use the point of care device. We developed a curriculum for them that they could use in terms of providing necessary counseling and education to parents, after that they've conducted the test. Yeah. And so these are some of our training sessions with nurses across the country. Yeah. And this is not an up-to-date table, but at just 2 hospitals in the country, and this was sometime earlier this year, okay, we were able to screen about 658 kids, of which 12, confirmed sickle cell patients. And but what's really interesting is the number for sickle cell trait. It tells you that it's a high burden country and going to have a lot of kids with sickle cell disease, as these newborns get older, and start having kids of their own. So there really is a need, for programs, that would, identify individuals with sickle cell disease, but also educate the ones with traits, about the implications for reproductive decision making. These are some of the kids, that we screened this year at different hospitals across the country. And what I really liked about this program is that at least, it allowed us to identify affected kids very early, put them into intervention or provide access to care. But more importantly, we begin to reduce that mortality rate, of 10% surviving beyond age 5. Okay. Again, as I mentioned in the previous slide, it's a country with a high sickle cell trait rate. So there is a need to educate individuals about sickle cell trait, the stigma around sickle cell disease, and for me, to provide information that individuals can now begin to think about or use, especially those individuals who have, or couples who have the traits, decision that they need to make around reproductive choices. It's also funded through the out-21 mechanism by NIH, and this program actually, our funding just ran out last month. In terms of results, we're still analyzing the result, but I think we trained roughly about 121 nurses across the country, and we screened 1,072 individuals. And most of these individuals that we screened were pregnant women who were presenting at antenatal clinics across the country. Again, so this is where some of the counseling or screening we've done, and just to give you some ideas of the individual that we are screening and the location of the screening. But again, it's yes, newborn screening is good. Sickle cell trait testing is good. Okay. But when you identify individuals with sickle cell disease, you now have an obligation to create, access to care for these individuals. Mostly because sickle cell disease is a lifelong condition. Okay, and what you can see from the slide is that from childhood to adulthood, adolescent adulthood, there are so many presentations that are likely to be experienced by patients with sickle cell disease. So they have to be in a comprehensive care infrastructure through time or over time. And so in Sierra Leone, now that we've implemented newborn screening, we have an obligation to provide care for these children. And so we are fortunate to get funding, about $500,000, from Novo Nordisk to develop pilots, 3 pilot clinics whereby we could use evidence-based guidelines to treat children with sickle cell disease identified at birth. Okay. And we've just established the first of 3 clinics in the country for this purpose. And these okay, so these are the locations of the 3 clinics that we're going to be establishing across the country. So the picture on this will be my left top, is a clinic that is up and running, functional right now. And the other buildings are sites across the country where we'll be implementing, the other clinics. And this is, of course, this is our model clinic, and I'm very proud of it because it is self-sufficient. We actually have our own solar power system, which is very important in places like Sierra Leone, where you do this type of work. Okay? And we're using NIH guidelines to provide services, and we're introducing wellness care model in an environment where folks only go to the hospital or to see a clinician when there's an acute presentation. So this is changing health-seeking behavior. And these are some of our clients. Okay, they look happy, they look healthy, and we're proud of the work that we do. Okay. I'm going to talk briefly about some new projects that we're also getting ready to implement. And one is we've determined, we've provided a system where we can identify kids with sickle cell disease. We created an infrastructure where they could go for care. But I believe that it's not always true that if you build it, they will come, right? You got to determine that, yes, they're using that facility. So our next project want to look at how do parents with kids with sickle cell disease seek follow-up care? We want to understand their health-seeking behavior. We want to understand how they use community support and how they network now that they are a community with very similar interests. Our other project is designed to increase awareness about sickle cell disease across the country. And so we are piggybacking our study on an existing pregnancy surveillance program. Okay, so, and working with a group called CHAMS that is funded by the Bill Gates Foundation. And they're looking at, oh, we don't need that. Supposed to be at the meeting.
You can hit the X, it's fine.
Yeah, it's not here.
Is that on yours?
But it's on both screens. Okay, here we go. All right. Yeah. So like this pregnancy surveillance program with about 4,000 to 5,000 pregnant women that have been followed for 20 weeks of gestation all the way to 45 days post-delivery. And so in that cohort, we want to screen everybody to determine whether they have sickle cell trait or not. And for those who have the trait, we also want to screen their partner to determine which couple is high risk and which couple is low risk. And so hopefully we might be able to get this program up and running in the new year. Okay. But I found, I'm about to end now, but I found out that for your program to succeed, you have to have a model where you're able to identify how that program is being accessed. And so we use a model that was developed in 2010. This could be a presentation, of its own, but I just want to make sure that as we are looking at how the center, the Sickle Cell Center here, is expanding its scope, you need to have a model that you could use to determine, whether you're meeting your objectives, and outcomes. I'm going to end with 2 slides, okay? I'm not sure how many folks would recall or have seen this slide before, okay? But I'll tell you, this was, this photograph was taken sometime, in the 70s. I think it was in California. And this was the Black Panther organization doing sickle cell screening out in the community long before it becomes the national program. Okay. So the point here is that it was community intervention. It was community initiative that brought newborns or sickle cell screening to the forefront here in America. So I believe that what we're doing in Sierra Leone mimic what the Black Panther, did here in the States. What we're doing is just a small footstep, but it's a very significant footstep. Okay, and I'll end with a slide. Thank you for your time.
From the audience.
Yes, ma'am.
I'm just wondering, does the Sierra Leone government have the capability, like if they're interested in trying to implement as this a national program, do they have the funding and capability to do that? Or is it going to require, resources from other countries to help try to implement this practice nationwide?
The answer is yes, okay, because like many developing countries, the healthcare needs are tremendous, but the resources to address much of those needs are limited. So most countries like Sierra Leone are what we call their health policies are donor-driven. Okay, so if you're a donor and you have your agenda and you're willing to fund that agenda, that's how policies get implemented. And so, but what we have been doing in Sierra Leone is create models that if and when the government, is able to, to consider sickle cell disease as a healthcare priority, which they do, these are models that we've tested in that environment, and we're able to show that those models work. And so all they have to do is just implement that model, and just increase the scale. Okay. But recently, I think UNESCO has offered some money to fund sickle cell project in Sierra Leone. And for our Novo Nordisk funded project, we have now arrived at an agreement with the government of Sierra Leone to bring them in as partners. And Novo Nordisk made a commitment that they're going to continue to fund this project by way of expanding additional nursing capabilities. So what do I mean by this? That they're going to provide funds for us to train nurses how to prescribe and monitor hydroxyurea usage in sickle cell patients. So that's a new skill that nurses will acquire. They're also going to provide funding for us to train nurses how to implement TCD, which is an important intervention to identify kids who are likely to experience stroke. Okay. So again, so with government partnership, we now have an opportunity to increase the scope of the services that could be provided in the country, and also the capabilities of nurses in terms of what they can do. Yeah. Yes, sir.
For patients who are having like severe complications and need like a blood transfusion, for instance, are you typically able to get units of blood to Sierra Leone, or do you have challenges with that?
I mean, they could have that in government-run hospitals or in private-run hospitals. Our model is focused on the wellness care model. So basically, we want our patients, to understand that sickle cell disease requires maintenance, that you don't have to wait until there's an acute presentation, that with routine monitoring and management, I mean, you'll be able to live, a better life, and you'll be able to avoid the complications that comes with having access, to wellness and routine care management. You have a question, Miss?
With your experience and background in behavioral health,
Yes, sir.
how has that been utilized at all in your Sierra Leone model at this point?
Oh, you mean the embracement of wellness care?
Well, I mean, yours is in mental health and behavioral health, and it seems like you're in some of the models that you're implementing, you're trying to get just the basics. You're trying to get newborn testing, that kind of thing. Where does your layer, where your expertise lies? Where does that eventually come into the nursing model?
Okay, so as part of our routine care, okay, we are now screening for depression, anxiety, not only in our kids, but also in the parent. Okay? Because I subscribe to the notion that wellness care for sickle cell disease transcends the patient. It's especially for young kids. You have to include the parent, for the simple fact that in Sierra Leone, it's expensive to have a kid with sickle cell disease. Okay? And having a kid with sickle cell disease has the tendency of breaking up a family. Why is that? Men, and this is true, men refuse, I'm not sure because of a lack of understanding of genetics of sickle cell disease, inherited pattern, but refuse to think that they have any role in a child having sickle cell disease. Okay. It's also a disease, that has a lot of stigma attached to it. Again, that because of lack of awareness. And so it has a way of impacting the well-being, but also the integrity of the family. So we're trying at the basic level, to at least, ensure that we're monitoring, the mental health of the family as well. That's how far, I have used my expertise with sickle cell disease. One of the things, though, that I have been struggling with is when you implement a new program, there are always unanticipated ethical dilemmas that will emerge. Okay, and we are at a very early age, having to deal with some of those dilemmas. Like, for example, you test the kid has sickle cell disease, the mom has sickle cell trait, the father doesn't have sickle cell trait. How do you share that result? How do you make sense, and what's our role, as the implementer of newborn screening? Okay, we have couples, who with the woman is pregnant. You screen that individual. She has a trait. You screen the partner. The partner has sickle cell disease. or some form of sickle cell disease that have very mild presentation, and so that individual is not even aware that they have the condition. And you know that, oh, that pregnancy, they're going to have a kid, So how do you make sense of that, in an environment where the care is not readily accessible, the family does not have the means, to support, a kid with a genetic condition. So those are some of the mental health, but also ethical issues that we have to deal with.
Yes, as you say that it is genetic
Yes.
disease, right?
Yes.
So is there any testing during pregnancy which can be done, or is anything under
You
development?
mean like antenatal?
Yeah. Yeah.
That aspect of care is not well developed, but I will say though that you also have in families, that have the means, and they could go elsewhere out of the country, for instance, Europe or some other African countries where they could do antenatal care. I mean, there are families with kids with sickle cell disease that receive the best care.
Mhm.
It's just a function of, our, your socioeconomic status.
Yeah.
Thank you. We're at time. So again, thank you for the presentation. Thank you for your visits. And again, you're very familiar with South Carolina. He's on the you're a South Carolina what is it?
Well,
Not South Carolina State Guard.
Okay.
State Guard, yes.
I used to be faculty at USC in Columbia for 3 years, and I'm also an active commission officer in the South Carolina State Guard. And so tomorrow I'll be in Columbia, doing my state guard function. So.
So you're here anyway.
I'm here. I'm in South Carolina. I work from home.
Again, thank you for your presentation. Everybody have a good weekend, and I think thanks for attending. And the code for CME credits on the board.